I was asked to touch base on the topic of radiotherapy and radiosurgery for glial tumors. And first we'll focus on the therapeutic options for high-grade gliomas, and of course we take care of these commonly, and of course we have resection and different radiation modalities, including 3D conformal concepts that Dr. Baumann mentioned, IMRT, brachytherapy implants with I-125 or in Europe other isotopes, stereotactic radiosurgery, stereotactic radiotherapy. In fact, surgeons for 30 years have been trying to maximize the amount of radiation given to this difficult tumor. And of course, over the last 20 years, a myriad of different chemotherapy options. As you know, this goes back a long way, and some of the fundamental principles for choosing radiation for malignant glioma has been based upon pathology and autopsy data. And a fundamental one is the issue that this tumor tends to extend 2 to 3 centimeters, or typically an inch, from the enhancing tumor seen on imaging. And when the CT era came out in 1975, that was a fundamental tenet that helped with radiotherapy planning. This followed with some science, particularly by Pat Kelly and Dumas Dupour in the 1980s, where biopsies were taken at a distance, showing that there were tumor cells away from the enhancement, and that low-density area was simply not edema, but in fact the water content of too many tumor cells being apart away from the tumor. And of course, we also know that with MR spectroscopy, what we see as the most metabolically active part of the tumor may not actually be what's contrast enhancing. So where we focus radiation on, particularly from the neurosurgical side, boosting it with radiosurgery, other concepts, back in the 90s, more brachytherapy, we always focus on the enhancement. And in fact, that may not be where the biggest problem lies. So currently, when a patient has a malignant glioma, based predominantly on work from RTOG, the Radiation Therapy Oncology Group, 60 gray and 1.8 gray fractions is a standard dose for a malignant glioma, and the target is the tumor, typically the enhancing volume, plus 3 centimeters. The issue is, should we do something on top of that? When would that be? Would it be right after radiotherapy? Would it be months later at recurrence? These are some of the issues. And of course, a number of years ago, the concept of adding concomitant temozolomide to radiotherapy was well received by the literature, and it's here by Roger Stupp, and so-called the Stupp regimen for giving temozolomide together with radiotherapy is now standard management in many centers. And here you see the results of that study showing that the combined results were better than the radiotherapy alone in this well-populated trial with over 500 patients. When we get to low-grade gliomas and the use of initial radiotherapy, things have been quite controversial. And again, work goes back to the 1980s into the 1990s. I would say that the main controversy 20 years ago was whether a patient should be radiated at all. But nevertheless, studies in the early 90s, coming out of the 80s, were showing that median survivals for low-grade gliomas, that being typically fibrillary astrocytoma or oligo, were in the range of 5 years. And it was difficult for me personally to accept median survivals of 5 years and doing nothing. So at our institution, we've always had a bias to treatment as opposed to no treatment, even though there was not a lot of proof that radiotherapy provided great benefit to low-grade gliomas. Of course, something dramatic happened since the 1990s, which has been the complete recharacterization of the histology of these tumors, and that so commonly a biopsy showed an astrocytoma. Many of those astrocytomas are now being called oligodendrogliomas based upon their molecular phenotype, and even a tumor that looks under the microscope like an astrocytoma, if it has a 1p19q deletion, many pathologists are calling it an oligo despite what it looks like under the microscope. So in fact, some of the lessons we learned correlating histology to outcome from 15, 20 years ago may be essentially irrelevant now, and that's somewhat of a travesty. We've got almost a moving target in this disorder. Nevertheless, a number of dose regimes have been studied in low-grade gliomas, and you can see in this study by Ed Shaw, now at Wake Forest, formerly at the Mayo Clinic, median follow-up 6 years, no difference in survival between these doses. for that reason, typically a lower dose between 45 and 54 gray, remember 60 gray for malignant gliomas seems adequate. Of course, the consideration of chemotherapy, either with radiation for malignant oligos or by itself for typically low-grade or grade 2 oligos, is another option. There's also this recent interest in delaying radiotherapy after diagnosis until there's tumor progression, almost cycling back to the 80s where observation was frequently a consideration. So why do we have this limit? And Dr. Baumann talked about why certain critical structures may be limited in terms of dose, and typically the optic chiasm is a very important issue for temporal lobe, frontal lobe tumors, 55 gray being a standard dose limit. And we've learned a lot of lessons over the years, not just from the malignant glioma experience, but from pituitary tumors and meningiomas of the skull base. The orbit is a dose-limiting factor. The lacrimal gland, we don't often talk about that structure in neurosurgery, but there are dose limits for the lacrimal gland similar to the salivary gland that radiation oncologists know about that we typically do not. There are dose constraints for the eye that was mentioned earlier, and these are other issues that may limit dose selection in certain kinds of cases. And of course, there are dose constraints for the pituitary, where 50% of the gland getting less than 35 gray potentially can lead to pituitary deficiencies. And Dr. Germano showed, very nicely that at 10 years, patients receiving fractionated radiation to that region typically are almost all showing signs of hypopituitarism. Of course, in a glioma situation, that's maybe a little less relevant. And then we have dose constraints now on the cochlea, and we're learning more about cochlear sensitivity. We're learning about it in radiosurgery as it relates to hearing preservation for acoustic neuromas, and these types of things, trying to avoid otitis, bone necrosis of the petrous bone, and so on. Again, you can see that the limits around 52 to 65 gray, again, staying below 60 gray, are important. So if we want to boost, if we leave that alone and talk about those as being the general initial fractionated concepts for both low-grade and glial tumors, if we want to do more for a malignant glioma and lead to a boost or essentially a doubling of the radiobiologic effect of 60 gray in 6 weeks, then that either is brachytherapy or some form of focused radiation. We'll call it radiosurgery. And this has been criticized. And why is that? Well, the first of all is that this tumor is invasive, and radiosurgery is a focal way of radiation delivery, and some say it's too focused. It makes no sense to deliver a focused volume when you know there's tumor cells at a difference. And for this reason, that's why radiosurgery is never used alone in the management of a malignant glioma. Second, it's giving radiation perhaps in 30 to 60 minutes. And this is only targeting one cell cycle time. And if cells divide, some divide today, some divide tomorrow, some next week, and when they're exposed to their sensitivity for radiation, when you give radiation in 30 minutes, you're not tackling all of those at their most vulnerable point. And of course, the imaging, if you target the enhancement, that's really not correlating completely with the tumor. And for that reason, there is some interest in targeting away from the enhancement at the regions of spread, for example, tumor going into the corpus callosum, targeting the invasive pathways. So what is the radiobiologic rationale? We did some work in my lab back in the 90s looking at animal models, rat malignant glioma models, of adding radiosurgery to radiotherapy. We implanted rats with malignant gliomas and let them grow for a couple of weeks, targeted them with the gamma knife, which could be done well. You can see an untreated tumor here, leading to a mass lesion and death of the animal at 22 days. Here is 90 days later after radiosurgery. And if you looked at survival curves, no matter what we did, adding radiosurgery at different doses or a LINAC boost and so on, all of these led to significant survival benefits over simple radiotherapy alone. So the concept of a boost to radiotherapy has, in an animal model, something that's been very desirable. At a more molecular level, we've also characterized what happens to the tumor within the first 24 to 48 hours after radiosurgery. And tumors die through a number of mechanisms, as we all know, not just necrosis, but apoptosis. And we've been able to show that within this very short period of time, almost within the first day, suddenly cells become apoptotic. These are the dark cells on the left, as compared to non-irradiated cells on the right, which remain non-apoptotic. And of course, these are the kinds of things that we want to happen. So in the 1990s, a number of things happened. First, there were several randomized trials of brachytherapy that showed no benefit. So a brachytherapy boost did not lead to a benefit on top of external beam radiation for glioblastoma. And some of those studies, particularly some elegant work from London, Ontario, showed that selection bias was a key, that simply the patients being selected for a boost typically had smaller tumors or in better neurologic condition, were more favorable. But this was work where we did radiosurgery as a boost to external beam, compared them to RTOG controls. This is retrospective data. And you can see, for example, the median survivals being better on the radiosurgery side, particularly if you look at the 2-year survival curves of grade 4, grade 5 patients. These are older glioblastoma after resection, after radiotherapy. Again, the tail of survival was better with a radiosurgical boost. There have been probably a dozen studies that have shown exactly the same thing. These are non-randomized, selected clinical studies of typically smaller volume malignant gliomas in patients with good clinical condition, showing a benefit to a radiosurgical boost. And then this study came out, this RTOG study, which looked at something completely different. And what this study targeted was the use of radiosurgery up front. It was the initial management after a resection or a biopsy, and radiosurgery was done, followed by external beam and CCNU chemotherapy. And you can see the slide on the right that the radiosurgery boost did absolutely nothing. The survival curves were identical to radiotherapy alone. And we were quite critical of this study because, in my opinion, it addressed a question that was almost moot, which was the role of upfront radiosurgery, which was rarely practiced by anybody. And so why did the RTOG and others spend a lot of money on this randomized trial? Well, the reason was that they didn't think accrual would happen if radiosurgery was performed later. The tumors would be bigger, the volumes would be larger, and accrual would be difficult. So the issue was to try to get the tumors as small as possible at the beginning, and they clearly showed that radiosurgery for all comers makes no sense. So the issue right now is whether radiosurgery is for all comers. And our thoughts on this the answer has always been no. Radiosurgery is for a specific type of malignant glioma, and that is for the ability to treat more powerfully to a small volume. And here's the University of Florida experience. Again, increased survival with RPA class 5 patients, similar to what I showed you before. Age over 50, glioblastoma, good Karnofsky, post-RT. Another study from University of Texas in this matched cohort analysis showing the same thing. Another study from Northwestern using the recursive partitioning analysis, but again, not randomized. Adjuvant radiosurgery at time of progression seems to improve overall survival, again, for highly selected patients. So in 2010, using the available literature as it is, why consider this for a recurrent GBM or anaplastic gastro? Well, certainly if there are no other options or no further useful chemotherapy related to bone marrow status or failure of other drugs, the volume is small. If you're trying to palliate further, the location is not amenable to further resection, we think that radiosurgery is an appropriate strategy. And we are not doing a lot of radiosurgery now for glioblastomas, mainly because there's such a strong interest in using different chemotherapies and molecular targeted agents, so that when one fails, our neuro-oncologists simply begin another drug. And in my opinion, they are underutilizing radiosurgery for this tumor. So what I think are the important issues to consider when you're performing radiosurgery for a malignant glioma is dose, and we give as much as possible given the volume and the location. So we talked earlier about organs that were critical. Well, if someone's got a recurrent malignant glioma, they're going to die soon potentially, and we're therefore willing to accept more risk, particularly if resection is an option later on. So we will push the dose as high as possible to the margin. Whether they should have radiosurgery or hypofractionation, remains at your discretion. But typically, we do upfront radiotherapy and a boost several months later. And of course, if it's down the road, they would get radiosurgery alone. How do we do this as safely as possible? Well, precise and conformal target delivery. However, if you target radiosurgery beyond the area of enhancement, you should expect that that brain is going to enhance. And of course, in the tumor world, we don't like to see enhancement because everybody interprets it as recurrent tumor. But remember, if you're giving 20 gray to brain parenchyma that has tumor cells in it, but it doesn't enhance, you're going to disrupt the blood-brain barrier, and that brain is now going to enhance. So if you look at the 3-month scan, the 6-month scan, and everybody's panicking because now there's more enhancement, you have to realize and tell your colleagues that, hey, this is what we should expect. And because of that, adverse radiation effects are not necessarily a bad thing if you can manage it. Obviously, if it's in a critical location, it can be more problematic. Can you do it again? Sure. If the volume is similar, but again, expect radiation effects and blood-brain barrier disruption if you're retreating it. And what is the role of the neurosurgeon in this setting? Well, in our practice, it's pretty much everything. It's frame placement, facilitating the tumor imaging over an MR, reviewing it, doing the dose planning either with your physicist or radiation oncologist, participating in dose selection with your radiation oncologist, confirming proper anatomic setup, which typically you have to make sure there's no errors there, assessing proper completion, and then facilitating the post-op care because these patients are typically admitted to you and are on your service, and you're often the one going to be dealing with any morbidity. And what is the target? The target traditionally has been the contrast-enhancing tumor, although others are currently interested in treating the invasive changes on flare sequence, the so-called leading edge, where the tumor may be spreading into the white matter pathways or the corpus callosum. Briefly, our experience looking at several hundred patients with GBMs, you see the volumes are not very big. 4 cc's is relatively small. Here's anaplastic astrocytomas. Again, the volumes are fairly small. And our eligibility criteria are typically tumors less than 3.5 centimeters, although I'll accept even 4.5, mainly because if there are no other great options, we'll be broaden this a little bit. And here's a recent case of a patient sent from Peru with no diagnosis, had a presumed GBM. We did a stereotactic biopsy and then performed radiosurgery. He was sent up purely for radiosurgery, which was an inappropriate concept, and then arranged for him to have external beam radiation and temozolomide in Peru. But you can see this volume is not terribly small. The diameters are about 3 centimeters in all planes. I think some of the clinical factors we consider to the radiosurgery effect is whether they had radiotherapy. They may not if they're quite elderly. The role of chemotherapy, location, whether they present with seizures, age, and whether they've had a craniotomy. Some of the variables you'll need to consider is volume, obviously, and dose correlates with volume. And this 12 gray volume is a measure of the amount of radiation delivered to the brain beyond your target, which can correlate with morbidity. So here's a tumor, and you can see a 3-month scan and a 6-month scan and an 8-month scan as a boost to prior external beam. I would say this is about as big a volume as we would consider in our practice. Here's a small volume of a tumor after prior XRT and BCNU with an anaplastic astrocytoma. Prior resection has a recurrence, has radiosurgery to this relatively small volume, and here's a 15-year scan on the right. And of course, we all have these anecdotal long-term survivals of malignant gliomas, but that one was one managed aggressively. Median survival in GBM in our series has been 18 months, but more importantly, if you start to look at clinical factors that are relevant to certain patients, those with lobar tumors, 18 months versus deep tumors at 11 months. If you look at prior XRT versus a small group without it, obviously quite elderly, the radiated patients are doing better. Those who get chemotherapy are doing better than those who don't get chemotherapy. Male and females do equally well, and younger age, does better than older age, of course, and prior resection seems to do a little bit better than simply having a biopsy, and survival after the procedure being about 10 months. So you can see that the difficulties in looking at the literature on radiosurgery outside of randomized trials have been well matched. There are just so many variables that impact upon survival that when you simply add one more, you're going to need a large volume of patients with multivariate testing to sort this out. But something intriguing is that, and Dr. Germano showed some very prompt shrinkages related to metastasis, is that at the 3-month scan, when we see a tumor is smaller at 3 months, median survival is 33 months, not 18 months. So when we get a prompt radiobiologic effect right off the bat, that bodes very well, going forward. What's been the price to pay? Radiation effects have been relatively uncommon, probably because many patients don't live long enough even to get a radiation effect, but at 6% for malignant gliomas. And of course, some of them come to other forms of management, including repeat procedures for distant volumes, more chemotherapy, and sometimes additional craniotomies. So I think that over the last 20 years, beginning with our understanding of how to do radiotherapy in the best, safest way possible, and then selecting patients for boost techniques has been valuable to those specific patients. And certainly boost radiosurgery is not appropriate to all patients with malignant gliomas. A randomized trial has shown no upfront survival benefit, but it should be pursued in selected patients. I just want to finish by showing you some things related to other gliomas and what exists in children, for example, with pilocytic astrocytomas. This is a tumor that, for one reason or other, can melt away after radiosurgery, and especially in the young developing brain where we're trying to avoid large field radiotherapy, I think the concept of doing something very focal with any of the available techniques is desirable, and there's an expanding literature on the role of radiosurgery in pilocytic astrocytomas, and typically done under general anesthesia in young kids. Here's a 4-year-old girl, biopsy proven in the pons. Here's the 1-year scan. This child's now 15 years old with no tumors. Here's a neurocytoma. This is something we used to, always do a transcallosal resection on. Now I typically manage these with a biopsy and radiosurgery alone because this is a tumor that seems again to melt away, and you can see the response of that tumor. So I think that's it, Steve, and we can call the discussion.
Fantastic. Tour de force, as usual. Just a note to our participants, the webinar will be concluding probably in about 5 minutes or so. I wanted to get to a couple questions, not only the polling questions, but we have a few questions from the audience for you. The first one is, when you're dealing with a tumor with a non-enhancing, a tumor cyst rather, with a non-enhancing rim, do you routinely include that as part of the target?
Yeah, that's a great question, and we initially did not, and just tried to treat the tumor nodule to, have that nodule stop making cyst fluid. That always failed. So we know that there are tumor cells along the rim of those cysts, particularly when they enhance, so you have to treat the whole thing.
Great, okay. And the second question has to do with the role of Avastin. If you could just take a minute and sort of let us know your thoughts on whether or not you think Avastin makes radiation safer in the sense that perhaps it has a role against protecting against radiation necrosis.
Well, it's certainly been used in a small series of patients to manage adverse radiation effects. There's a paper on 8 patients from MD Anderson. We don't have anybody that has had it at our place, although I've referred one patient for it, and they haven't got the drug yet. So I don't think it's necessarily a protector in advance of the procedure, although I'd be interested if you have any experience with that, but we certainly do not. But I can tell you what it is doing. It's reducing our volume of radiosurgery for malignant gliomas because patients who are getting it are seeing a reduction in enhancement, which may be temporary in some patients, and that's delaying the role of a boost technique for some of them. But maybe that's good for their patients too.
That's been exactly our experience at Henry Ford too. So we'll see where that leads us, I guess. But all right, well let's go on to the first of the last 2 questions. Basically, the first case is the following: Malignant glioma radiotherapy is performed according to a specific dosing and target regimen because A, since the tumor always progresses, the dose is only based on safety for other regional structures, or B, multiple dose regimens were tested during the 1980s and 60 gray was found to be optimal. C, since tumor cells rarely extend far beyond the volume of contrast enhancement, the target volume extends only 1 centimeter beyond the enhancing volume. Or D, the cell cycling time is relatively slow, so radiotherapy over 6 weeks is best. Please, again, choose your correct answer in the poll to the right and submit it. And while we're waiting, I'd just like to remind everyone that summaries of all of the data generated from these sessions, as well as summaries of the actual sessions, will be made available to all of you. You'll get an email link tomorrow inviting you to participate in an online blog where everyone can ask further questions of our faculty members and of each other, and all of that will be summarized as well. So hopefully the goal overall is that this online community discussion will grow and it will allow everyone to share their experiences and contribute to our collective knowledge base in neuro-oncology. And as a reminder, we encourage questions and debate, and participants can pose all of these issues and questions to our faculty online now and in the blog and by email links after tomorrow as well. And as soon as the session ends tonight, I encourage all of you to stay online so that you can fill out a post-webinar survey questionnaire, as well as to fill out a form to get CME credit for this session. So most people, Doug, it seems, have chosen choice B, which I believe is correct. Can you take us through that?
Yeah, they got it right. So particularly RTOG did a number of studies during that time and found that 60 gray was optimal. Turns out that 1.8 gray fractions are safe, and using delivery on Monday through Friday, it takes about 6 weeks to get up to 60 gray. So that kind of answers D. We know the cell cycling time is relatively quick. And of course, tumor cells extend well beyond 1 centimeter, and tumor doesn't always progress. That seems a little nihilistic even for neurosurgeons.
Great. Okay, perfect. Let's go on to the last question of the night. Class 1 evidence exists for which of the following statements about stereotactic radiosurgery for malignant gliomas? A, radiosurgery is indicated for small volume biopsy-proven gliomas after radiotherapy to maximize the radiation dose delivered to the tumor. B, radiosurgery is not indicated for a recurrent tumor. C, radiosurgery given upfront followed by radiotherapy and chemotherapy provides no survival advantage. Or D, quality of life is improved when radiosurgery is used as a boost to radiotherapy. Again, if everyone can take a moment to answer those questions. And Doug, perhaps you can just start going through.
Well, although I may believe A, there's no Class 1 evidence for that.
Right.
So it certainly exists for C, that there's no role up front. And we can just leave it at that, I think.
Great. Okay. All right. So, yeah, the correct answer here is C, radiosurgery given upfront followed by radiotherapy and chemotherapy provides no survival advantage, at least in terms of Class 1 evidence results. So the poll will be up momentarily. There's still time to ask questions and again, to participate in the online blog that all of you will receive a link for. And congratulations again to the majority of you for getting the correct answer.